So I'm going to try and give you an overview of where we stand in our current thinking of spasmodic dysphonia, and then talk about the grants that are now funded by NIH on spasmodic dysphonia. 3 years ago, if I'd given you this talk, I would be talking about 0 grants at NIH on spasmodic dysphonia, and we now have 13 grants. So there is huge progress being made in funding, and that's thanks to NSDA and the Advocacy Day. That has had a huge effect on funding for spasmodic dysphonia. So keep up the good work. You guys are really doing terrific work. Okay, I'm going to talk about some recent studies that are not what we'd call hardcore scientific studies, but they're providing us with some insight to people who have spasmodic dysphonia and what might be some of the risk factors for spasmodic dysphonia. The first one is a simple discussion of the characteristics of 150 cases of people who had spasmodic dysphonia, and this was done at the University of Utah by Christy Tanner and her colleagues. And just to overview, 63% of their population was female, which is a little lower than we've seen in some of the other studies. 76 had a gradual onset rather than a very acute, abrupt onset. 27% had vocal tremor as well as spasmodic dysphonia. And those who had vocal tremor did report, at least half of them, that they had some benefit from medications. Now, this group of patients were all seen at University of Utah, which is a medical center, and so it's no surprise that 96% of them had all had some kind of treatment for their spasmodic dysphonia. Interestingly, 89 had had botulinum toxin injections, and 91% of them reported that the botulinum toxin injections benefited their voice, and we know that. That's commensurate with what we've seen in the literature. 59% had had voice therapy, and 22% of those people reported that they had some benefit. 7% had had surgery, and 45% of them reported benefit, and about half of those cases were people who had had the denervation reinnervation procedure. Now, changes over time was the first time, this report is the first time they've talked about changes over time, and some of these people had had spasmodic dysphonia for over 20 years. And what was interesting is that 21% said that they got better over time, 34% thought they got worse, and this was gradual over 10 years, and 45% stayed the same. So there seems to be a little bit of a mixed picture. And I'm going to talk about that a little bit later. They had the patients all fill out this quality of life questionnaire, and they did it over time when the patients came back each year, and the patients had improved over time since their diagnosis. So although they reported their voice was either getting better or getting worse or staying the same, their quality of life was all getting better. And that's good. They'd physically function had improved over time, and their total score had improved over time. Their overall quality of life had improved. Their socioeconomic changes had not improved to the same degree, and I'm going to talk about that in a minute. Now, does having tremor with spasmodic dysphonia make a difference? Because this is important. If we're going to do genetic studies, if we're going to do other studies to try and find biomarkers, should we include just the patients who have SD without anything else, or should we include the patients who have tremor? And should we include the patients who only have tremor? Because that's really important. Are they part of the same disorder family? And as I mentioned earlier, in this cohort, 27% had tremor, and they compared the patients who had tremor only with the other group and found no differences in the characteristics of the population of those who had tremor versus those who had spasmodic dysphonia. So in progression, in frequency of treatment, voice therapy or surgery, their response, gender, and the only difference was that medications helped some of the patients with tremor, suggesting that the tremor component might be a little bit different in its response to therapy. Now, another study that is in press right now It came from Emory University, and there they wanted to look at the age-old question of whether people with spasmodic dysphonia have more depression or more anxiety than other people. And they did an interesting thing. They compared the spasmodic dysphonia patients with other patients who had voice disorders that were thought to be separate from spasmodic dysphonia, such as muscle tension dysphonia. So they found that 28% of 128 patients with spasmodic dysphonia reported that they had more depression since they developed spasmodic dysphonia. However, when they looked at 14 people with muscular tension dysphonia, they reported the same thing, and in fact, it was a little bit more frequent. They looked at anxiety, which is another big report in spasmodic dysphonia. 25% of the patients reported they had anxiety. 29%, however, of the patients with muscular tension dysphonia also reported anxiety. And what they found was the duration of the disease was a predictor of depression in both groups. The longer the disorder, the more frequent the depression. So depression can be a result of the voice disorder. And the take-home message of that is get involved in your support groups. Keep your involvement in the NSDA. That really helps in supporting patients and not feeling isolated. So I think that we now know that, the data suggest that the anxiety and depression may be secondary to the disorder. And this is happening in other dystonias, and it's still a question that needs to be resolved. Now, I'm going to talk about a fair amount about a case control study. This was a study done by Christy Tanner. It was the same 150 spasmodic dysphonia patients. And they analyzed the data to compare these spasmodic dysphonia patients with patients who had other head and neck disorders. So these were patients with reflux, patients with sinus infections, all sorts of other head and neck disorders that were not related to spasmodic dysphonia. And the reason they did this is they wanted to find out what are risk factors that are particular for identifying whether a patient is going to have spasmodic dysphonia or whether they're going to have these other disorders. Are there certain risk factors that are associated with spasmodic dysphonia? And they did these analyses in 3 different ways. They first of all looked at all patients with spasmodic dysphonia, whether they had tremor or not. Then they looked at the spasmodic dysphonia patients with tremor, and then the spasmodic dysphonia patients who only had spasmodic dysphonia. And they looked here in this analysis for problems that were coexisting with spasmodic dysphonia. And I think this is really interesting because they looked at what things co-occur in patients with spasmodic dysphonia that do not co-occur in patients who have other head and neck disorders. And they found some interesting surprises. Hand tremor was more frequent in patients with spasmodic dysphonia, whether they had tremor or not. Blepharospasm came out as fairly frequent in the population of patients with spasmodic dysphonia. Social anxiety, that could be secondary to the disorder, as I just discussed, but there was also a family history of other voice disorders, not identified what type, but just reporting that these patients had family history. The patients with tremor, there was a high frequency of essential tremor in these patients and other head and neck tremors. They also had immune disorders and thyroid problems and a fairly frequent reporting of panic disorder. But when they looked at spasmodic dysphonia alone, that is patients who did not have tremor, they found the hand tremor was still frequent, the blepharospasm, and social anxiety. So these are sort of new findings because we haven't had these results before. Now they looked at what happens in the families of these spasmodic dysphonia patients, and here again we had some interesting findings. The patients with spasmodic dysphonia with tremor had a family history of essential tremor, and essential tremor, as you should know, is one of the most frequent neurological disorders. It runs in families and it's relatively frequent. And so you have a lot of patients who have voice tremor as well as spasmodic dysphonia having essential tremor. They also reported tic disorders, ocular disease. We think this might be related to the blepharospasm. Meningitis, which is an inflammatory viral disease, and that's relatively rare in the population, but it was more frequent in spasmodic dysphonia. and cancer, we don't understand this at all, and compulsive disorder, which is another disorder that cropped up. If you look at the patients who only had SD and you looked at their immediate family members, so this is mother and father and siblings, okay, so directly related, they found essential tremor, tics, asthma, and cancer. So these are new findings, and we don't have these results before. Now, if you look at extended families, like grandfather and grandmother and grandchildren and uncles and aunts, then you see neurological problems and cancer in both the with tremor and without tremor groups. So these are still things that we don't understand, but this is a new finding. Now, environmental exposures, remember we talked about a multifactorial design. That is, that spasmodic dysphonia doesn't come from one cause, but rather an interaction of perhaps genetic factors and environmental factors. And here they had some fairly common findings in that patients who had developed neck and throat tension as a response to some injury, that had occurred frequently in both patients with and without tremor and with SD alone. Mumps in childhood was frequent in both groups compared to the controls. And what was interesting is if they'd had vaccines for mumps or measles, it was protective. That is, fewer people had SD if they'd had vaccines. In the group with tremor, an upper respiratory infection, which is also viral, so mumps is a viral, and upper respiratory infection was fairly frequent. If we look at the patients with SD alone, we see intense occupational voice use and volunteer voice use as fairly frequent in this population compared to other head and neck disorders. Now, I want to mention odds ratio because this is one way of looking at risk factors. If you want to find a factor that might be at risk for people having spasmodic dysphonia, you want to compare the frequency of that factor occurring in people with spasmodic dysphonia in comparison to people without spasmodic dysphonia. So an odds ratio of 1 means that as many people with spasmodic dysphonia are going to have that disorder as people without spasmodic dysphonia. So you have an equal risk of having that factor. But if you have an odds ratio of 2, that means people with spasmodic dysphonia, excuse my typo, are twice as likely to have that factor than people without spasmodic dysphonia. So I'm going to take the Tanner study results and put it together in sort of an integration of what this suggests to us. It suggests that we may have a genetic predisposition, and this is based on the odds ratio of essential tremor and blepharospasm in these populations in the study that was found by Tanner et al. There was an odds ratio of 7.4 having essential tremor. So that's a very high odds ratio for essential tremor, and 4.1 for blepharospasm. So this suggests some genetic predisposition, and it may be related to these two disorders. There was also a high odds ratio for viral exposures. 3.7 was the odds ratio for having meningitis in the cohort with spasmodic dysphonia or in directly immediately related members of the family. And 1.7 was the odds ratio for mumps. Then we find another factor that had high odds ratios, and that was intense voice use, either occupational, which was 2.4, or voluntary voice use, which was 2.1. So if we try and take these different factors and put them together, it suggests that maybe persons have a genetic predisposition. They are then exposed to a virus that has a change in the central nervous system that might make certain neurons more susceptible to developing abnormalities. Then there might be a confronting or an exacerbating factor such as voice use that induces those neurons to have a different physiology and to become firing abnormally, resulting in spasmodic dysphonia with or without tremor. So this is the kind of model, which is a multifactorial model, that is suggested by the data we have today. And it certainly may not be correct, but it gives us a way to investigate and lead our research in the future. Now, speaking of the future, I want to talk about those 13 grants that relate to spasmodic dysphonia. There are 2 institutes that fund these grants. One institute is the National Institute on Deafness and Other Communication Disorders, and that institute funds 9 of the grants. And the National Institute of Neurological Disorders and Stroke funds 4 of the grants. So if I had given this talk 3 years ago, as I said, there would have been 1 grant funded by the National Institute of Neurological Disorders and Stroke, and that would have been my laboratory. Now we have 13 times more grants. That is a huge advance, and that's thanks to the advocacy activities that NSDA has done. Now, I'm not going to go through this list right now, but I'm going to give you some highlights from each one of the grants at the NIDCD. And I'm going to give you some highlights from the ones at NINDS, because this indicates what we might expect to come out of this research. So first of all, we have a lot of studies that are looking at functional magnetic resonance imaging, which is our only way of getting inside the brain to see what's happening during speech and during other activities in people with spasmodic dysphonia. This is a non-invasive, doesn't hurt, and it's easy to do study. It's fairly technical and requires a good team to run the magnet. But Dr. Gunther is an engineer, and he has developed the primary model of speech production in the world. It's called the DIVA model. He's been doing this work for at least 15 years, and 2 years ago he decided to work on spasmodic dysphonia as a model and see how the changes in brain function are altering the speech model in the brain. So this is going to be very exciting to help us understand what is going on in the brain in spasmodic dysphonia. There are 2 other studies that relate to this, and one was just mentioned by Lori Azelius. Christina Semignon, when she was working at NIH, started a study using positron emission tomography to study different neurotransmitters in spasmodic dysphonia. She was particularly focusing on dopamine neurotransmission in the basal ganglia, and that work is still being analyzed. And then the study that just started this year doing structural and imaging to try and correlate the structural changes in the brain in relationship to the genetic abnormalities. Now, there's a study at University of Washington where Carolyn Baylor is developing a measure of communication participation. This will be very helpful for us to understand and measure the amount that spasmodic dysphonia interferes with the ability of a person to participate in communication. She's looking at several items in developing this, and the testing population that she's focusing on is spasmodic dysphonia, which is really exciting. So we will have a measure of how much spasmodic dysphonia disrupts communication. There are 2 studies at University of California in San Francisco that are looking at speech feedback. It's very interesting when I was last night listening to many of you who I know very well use the microphone and talk to the rest of the group. And your voice symptoms often change when you use a microphone, and sometimes they're better. This suggests that speech feedback may have a role, particularly the auditory feedback, in the functioning of spasmodic dysphonia. And that's exactly what Dr. Hood and a postdoctoral fellow in his laboratory are looking at, is the role of auditory feedback and how it might manipulate the symptoms in spasmodic dysphonia. And this might lead us to some kind of treatment model as well. Now, at Dr. Burks Lab, I don't know if I'll say Dr. Chitri's name correctly, but he is studying the complex interaction between the laryngeal muscles. And this is very important in looking at how muscles relate together or work against each other, and will be very important in understanding some of the interrelationships between the muscles in a disorder such as spasmodic dysphonia. At University of Minnesota, in the last 2 years, 2 new grants have been funded. One with Dr. Watson, and Dr. Watson is looking at sensory feedback in spasmodic dysphonia. One thing we know, if you spray lidocaine in somebody's nose before you do a nasoendoscopy, when they have spasmodic dysphonia, it changes the symptoms. We used to always joke about that in the clinic, that patients would come and see us and we'd get rid of their symptoms. But it really we think it has something to do with sensory feedback. And that's what Dr. Watson is studying in spasmodic dysphonia and comparing that with muscular tension dysphonia. And he's starting with limb sensory feedback. Dr. Kimberly, this grant has just started, and she's using transcranial magnetic stimulation to stimulate the brain and look at the muscle response in the larynx. And this is a way of testing that pathway that Christina Simenon found might be disrupted in the internal capsule in the white matter that you just saw the brain images from. This is testing that physiologically and will be able to help us determine whether there's a physiological basis for that finding. So this is very exciting. We also have Dr. Carolyn Tant Tanner, who is one of our members of the Board of Scientific Counselor of the Scientific Advisory Board, and she's studying patients in Kaiser in San Francisco, and she's recently gathered some prevalence data on how frequent spasmodic dysphonia is in the general population. She is finding it more frequent than the original literature suggests, so we are getting some good data on prevalence. But what she's just started to do and was working on is the misdiagnosis. How often are patients misdiagnosed, get the wrong treatment, and take a long time to get properly managed? And so this will be very important in bringing the attention of the medical community to the fact that many patients are not diagnosed correctly. Dr. Mark Hallett at NIH in the intramural program is looking at genetic markers in focal dystonia, and he's doing this work with the NIA. Dr. Handy Singletary is studying this with him. They are looking for all forms of focal dystonia and trying to find associated genetic markers. I wanted to also mention the Dystonia Coalition. As part of that, I'm running a Clinic 3 project, and there we're focusing on trying to develop a test for spasmodic dysphonia, because we are finding that often people who are experts disagree on the diagnosis of people with spasmodic dysphonia, so we are hoping that we can develop a test that will be more accurate for diagnosing spasmodic dysphonia. The way we're doing this is we have 3 centers that are participating in this, and they're diagnosing patients as either SD with or without tremor or muscle tension dysphonia, patients with tremor only, and then patients with muscular tension dysphonia versus other voice disorders. The idea is that patients with spasmodic dysphonia might be misclassified as the other groups and not get the appropriate treatment. And so what we're trying to do is see if we can develop a test, and we're using some external judges who are experts in the field to try and determine what test will be helpful for doing this. If we can develop a rating scale that's accurate, we can also train people to use this test and use it to measure different treatments. And we're finding that with the training materials, we can go from a 50% agreement to an 80% agreement on diagnosis, which should help us a great deal. Okay, so in summary, what our research areas are being covered? We have several studies on brain function. We have at least 2 studies on genetic markers. We have 3 studies on diagnostic markers, trying to find out if there's auditory, kinesthetic, or other ways of identifying spasmodic dysphonia. We have a study of the quality of life effects, a study of auditory feedback in spasmodic dysphonia, a study of kinesthetic feedback in spasmodic dysphonia, a study of the excitability of the cortex in patients with spasmodic dysphonia, and hopefully a new diagnostic test for the disorder. So probably in the next 5 years, these results will be coming out from the grants that are funded at NIH. Whoops. Oh, what difference will that make to you and to the spasmodic dysphonia population? There will be increased accuracy of diagnosis. We will be able to differentiate spasmodic dysphonia from other voice disorders. We'll hopefully be able to identify genetic risk factors that might put somebody at greater risk of having spasmodic dysphonia. We'll have improved understanding of the brain dysfunction, and we'll be able to model that brain dysfunction. Why is that important? That could be the basis for learning of new treatment techniques for modifying the brain dysfunction. Okay, thank you very much for listening.